Welcome again to our YouTube channel. Today we are going to discuss about the topic of anaphylaxis in pediatric population and its management. This is a very important topic, especially for medical doctors and even for patient population, medical students also. Welcome. Remember to subscribe to our YouTube channel so that you will see updated video on time. Probably you had already know something about anaphylaxis, so this would be a good question if you have any interaction, anything known about it for the cause. So this is what we're going to discuss about. So first, anaphylaxis was described as a potential life-threatening multi-system syndrome which can be caused by the sudden release of mast cell mediator into the systemic secretion. So there will be something that stimulates the release of mast cell mediator, like the histamines in the systemic secretion, which will cause reaction which will be known as anaphylaxis. So those agents, they are capable of inducing sudden systemic degradation of mast cell that will cause or produce what's known as anaphylaxis. So the pathophysiology normally anaphylaxis is type 1 hypersensitivity, which is immediate release. It can happen in 5 minutes, at least 2 hours following the exposure. Most of them, they can be IgE mediated or non-IgE mediated. The IgE mediated, this is either due to food allergy or bee stings. Non-IgE medicated, it can be due to medication like non-steroidal anti-inflammatory drug and the radiographic contrast. This is how the mechanism of anaphylaxis happen. First, there will be exposure to allergens, which will lead to mast cell or B cell sensitization and even activation. Then plasma cell will be released with release of IgE antibody. So once there will be another exposure or second exposure in the future, then there will happen oversensitization of mast cell, which is mast cell mediators like histamine, leukotriene, and other chemicals that will cause the symptoms. There will be localized allergic reaction or systemic allergic reaction. Localized, this will be to the skin, like allergic rhinitis. Systemic, this is really the anaphylaxis. So this is what I've been talking about. So once the cumulative effect of all mediators are deleted, they can cause either vasodilation if it's systemic, which can lead to hypotension and myocardial depression. So the cause of anaphylaxis, most common is food allergy. Like in most countries, the peanut is the most common cause, like in the US. Drug like penicillin, insect like bee sting, latex, vaccination, and even radiological contrast, they can cause anaphylaxis. So the symptom of anaphylaxis, that will be normally to have anaphylaxis, there must be affected system, like the skin should be affected. At least the free system should be involved. Either the skin, cardiovascular system, or respiratory or GI symptom, or gastrointestinal system. From the skin, you tend to see urticaria or angioedema, flushing. But remember that absence of skin finding does not rule out anaphylaxis. On the respiratory system, there can be wheezes, angioedema. On the cardiovascular system, there can be hypertension, dizziness, and even you can have a headache and seizure sometimes. This is what you can see. So seen on the symptom of anaphylaxis, they have been said on the skin that should be flushing, local or generalized, respiratory that can be conjunctival itching, redness, tearing and swelling, nasal itching, congestion, even nausea and sneezing. Gastrointestinal, the patient can present with abdominal pain, nausea or vomiting, serious that can be chest pain, tachycardia and hypertension. Central nervous system that can be behavior change like irritability, throbbing headache, and even a confusion and even confusion also can happen. Those are different symptoms we can see. This is the presentation of skin finding in the case of anaphylaxis. The first picture shows the urticaria and hives. The second one is flashing, and the last two pictures showing angioedema. So the differential diagnosis of anaphylaxis, there can be asthma. If sometimes the patient is only to have asthma, they present with anaphylaxis, it will be very hard to differentiate. There can be panic attack. There can be foreign body aspiration, caustic ingestion, food poisoning, and even a croup in children also can mimic anaphylaxis. So the diagnosis of anaphylaxis, as I had said, there are criteria. There must be acute onset of symptom, second 2 minutes of skin and the mucosal involvement, like those hives, flushing, swollen tongue or even uvula, respiratory compromise like a dyspnea or wheeze, even stridor and sometimes. So even the blood pressure can be low and the sign of end organ failure. So 2 or more of the following that occur rapidly after exposure to a regular region for the patient, like skin mucosal involvement, respiratory compromise, reduced blood pressure, persistent gastrointestinal system. This one can mimic anaphylaxis. So but remember that low blood pressure after exposure to a known region in infant children also can be like low systolic blood pressure, can be a marker of anaphylaxis. But remember in pediatric, we have to plot blood pressure to say that is hypertension or hypertension. Remember that anaphylaxis is a clinical diagnosis. Sometimes treatment as a liver needed to be corrected between 15 minutes to 4 hours after symptom onset in the patient of any age. Treatment as liver even in the normal age does not rule the clinical diagnosis of anaphylaxis. And remember that in many settings, those treatments livers are not being done. So this is like a clinical case. 11-year-old girl who presented with sudden onset of severe symptoms after insect sting. Patient was stung by insect while playing outdoors. Within minutes, developed rapid swelling around the sting site, hives, and difficulty of breathing. Parents were administered an epinephrine auto-injector and brought her to the emergency room. Clinical presentation rapidly progresses. Symptoms: there will be facial swelling, generated hives, difficult breathing, high-pitched wheezing, and audible breath sound. Anxious appearance, increased heart rate, noticeable of pre-insect sting or non-allergy. So physical exam at presentation: temperature of 6.5 degree, heart rate of 118, BP of 96/44, respiratory rate of 44, oxygen saturation of 87% normal. Hand swelling and redness at sting site, diffuse hives on the skin. There was audible wheeze on scleration in the rapid heart rate, which is tachycardia. So how do you treat this patient? So the gold standard in the treatment of anaphylaxis is adrenaline or epinephrine. There is no absolute contraindication to administer adrenaline in the child. So remember, if you suspect anaphylaxis, you give adrenaline. So if outside the demand of the treatment, give it to code the blue. If it's very started distance of hypertension, then you press on continuous cardiorespiratory monitor to perform set of IV vitals. Immediately, if you are giving medication, you have to stop. Then remember to approach as ABC. This is an emergency. But the gold standard administer adrenaline at the dose, adrenaline at dose of 0.01 mg per kg with concentration of 1 per 1000 means 1 mg per milliliter EM, and may be repeated after 5 minutes. So if the patient has the hypertension on the C, you have to give normal saline bolus like 20 ml per kg IV bolus and administer oxygen. If you had respiratory failure, early intubation is the gold standard, and check vital sign frequently. So adrenaline injection is very important. How the adrenaline work? Act on the alpha-1 adrenergic receptor, where it increases vasoconstriction and increase blood pressure and decrease mucosal edema. On the beta-1 adrenergic receptor increase cardiac contraction force and increase heart rate. On the beta-2 adrenergic receptor, it increases bronchodilation and decrease mediator release. Those mast cell mediator histamine, they can be reduced by inducing adrenaline. This is how the adrenaline or epinephrine work in the case of anaphylaxis. So if stable after treatment, you can observe like in 2 to 4 hours after the last dose of epinephrine. There is some medication that can be used in the case of anaphylaxis, but not the first line. If you had urticaria, you can give the patient antihistamine like diphenhydramine. Even systemic steroid like prednisolone 1 to 2 mg per kg per day for 2 to 3 days can be given, but doesn't repress epinephrine, and even you can replace the patient if he has wheezes. So if one is stable, they have to be continuous monitoring. You can administer up to 3 doses EM epinephrine, repeating every 5 to 15 minutes, and give bolus every 3 days for hypotension, maximum 3 bolus, and check vital sign. If you still have a sign of anaphylaxis despite 3 bolus of epinephrine, this is the case where you have to give a continuous infusion of adrenaline to the dose of 0.1 to 1 microgram per kg per hour. Adjunctive therapy, as I said, if hypertension, you give normal saline bolus, oxygen, intubation if severe airway edema, and the if bronchospasm can nebulize with orbital or salbutamol. This is another case presentation. A 3 years old female will present with sudden onset of severe allergic reaction after eating a tree nut with no history of tree nut allergy, no pre-anaphylactic episode. Developed rapid onset of diffuse hives and facial swelling, coughing, wheezing, and troubled breathing, complaint of throat tightness and difficult speaking, acute abdominal pain and vomiting, hypertension, and para. Those are vitals. Distorted appearance, included respiratory fault, diffuse urticaria, facial angioedema, auscultatory with decreased blood pressure, hypertension. Biphasic reaction. So corticosteroids are too burdensome to prevent the development of biphasic symptoms. Biphasic actually means that you continue to have the patient has been treated for anaphylaxis for a period of time, then the symptom resolved after like a 2 to 3 hours, become again with symptoms of anaphylaxis. So this but use of steroid had not been systematically analyzed for the prevention of biphasic reaction. They can happen up to 72 hours following initial symptom. So protracted anaphylaxis also can occur, but it's rare. So biphasic reaction, for the frame biphasic or severe reaction, more than 2 doses of epinephrine required. The progressive persistence and sign of symptom. Reaction is too long, like medication. Even the patient have severe asthma, potential upper airway obstruction. Those are secondary therapy that can be used in treatment, as I have said. Diphenhydramine for urticaria, albuterol for wheezing, stridor. First, we consider epinephrine, like racemic epinephrine for nebulization. If there's heart failure, you have to intubate the patient. So discharge, if you're in a good setting like in US, where there is an allergist, there should be consultation with an allergist. If it's in a country where adrenal auto-injector are accepted, the patient should be home with it. And also, even at the school, if they have to go with those auto-injector, so that in the case of anaphylaxis, she can inject herself. Those are different auto-injector that can be used. Thank you very much. Welcome.